So, what are the changes that occur in heart failure? Basically, there are three changes that occur in heart failure. Number one, increase in systemic vascular resistance. Number two, increase in blood volume. And number three, increase in venous pressure. So, the neurohumoral responses that occur in the heart failure are the activation of sympathetic nervous system because of a decrease in blood pressure that leads to the arterial vasoconstriction. There is increase in renin, angiotensin, aldosterone system. There is increase in ADH or vasopressin, and there is an increase in atrial natriuretic peptide. All these factors, they increase the blood volume. The decrease in blood pressure leads to increase in renin secretion from JG cells. That increases the aldosterone, causes vasoconstriction, and aldosterone also causes increase in sodium reabsorption from the renal tubules and increase in the blood volume. The venous constriction leads to increased venous pressure, increase in blood volume, increase in ventricular filling, increase return. That leads to increase in preload. So the arterial constriction leads to increase in afterload, and venoconstriction leads to increase in preload. What happens when there is increase in preload and increase in blood volume? There is edema and pulmonary congestion. What are the effects of systolic dysfunction or systolic heart failure? There is loss of contractility, loss of power, so that decreases the stroke volume and cardiac output. There is dilatation, increase in preload and increase in end diastolic volume, and a decrease in ejection fraction. One thing common to both systolic and diastolic failure is that the left ventricular end diastolic pressure is increased in both systolic and diastolic failure. So, what are the causes of heart failure? Apart from the cardiac causes of heart failure, myocardial infarction, myocarditis, endocarditis, cardiomyopathy, and hypertension, the non-cardiac causes are, apart from COPD and pulmonary embolism, amongst the drugs that precipitate the heart failure are the non-steroidal painkillers, ibuprofen and indomethacin, and the calcium channel blocker, verapamil is an important precipitating cause of heart failure. The other precipitating causes are thyrotoxicosis and pregnancy. So, what is a low cardiac output heart failure? In low cardiac output heart failure, the cardiac output may be normal at rest, but fails to increase in exercise or on exertion. So, what are the causes of low output heart failure? Ischemic heart diseases, dilated cardiomyopathy, hypertension, valvular heart diseases, and the pericardial heart diseases. What is high cardiac output heart failure? In high cardiac output heart failure, the cardiac output may fall to within normal limits, otherwise it's high. The AV oxygen difference is normal or low. So, what are the causes of high cardiac output failure? Anemia, AV fistula, pregnancy, Paget's disease, beriberi, and hyperthyroidism. These are the causes of high output failure. Acute heart failure causes. The acute heart failure is usually systolic, but there is no peripheral edema. Whereas in chronic heart failure, there is a lead with there is edema and the causes of dilated cardiomyopathy and valvular heart disease. What happens in the left heart failure? The left ventricle gets blood from the left atrium and that receives from pulmonary veins. So in case of left ventricular failure, there is pulmonary congestion, dyspnea and orthopnea. And what happens in right heart failure? Right ventricle receives blood from right atrium and the systemic venous side. So there is hepatomegaly, venous congestion, increase in CVP and edema. So what are the causes of right heart failure? Are congenital valvular stenosis, pulmonary stenosis and pulmonary hypertension. So what are the clinical features and lab finding in heart failure? The clinical features are dyspnea, orthopnea, pulmonary edema, hepatomegaly and ascites. How much is the central venous pressure raised in heart failure? It's more than 16 centimeters of water. And how much is the weight loss after 5 days of treatment with heart failure? It's more than 5 kilograms. What are the X-ray features in heart failure? Curly's lines, increased vesicular markings, pleural effusion, and cardiomegaly. What are the auscultatory findings in heart failure? The auscultatory finding in systolic heart failure is third heart sound, and in diastolic heart failure is the presence of fourth heart sound. What do you find in echocardiography in coronary artery disease? There is regional wall motion abnormalities in the coronary artery disease. What are the atrial natriuretic peptide and B-type natriuretic peptides? These are the natural diuretics that are produced in heart failure. ANP is mainly produced from the atria and BNP is mainly produced from the ventricles but is also produced in the brain. The natriuretic peptides, they differentiates the cardiac causes from the pulmonary causes. The normal value is 100 and in heart failure is raised to 500 pg per deciliter. So what is the treatment of heart failure? There are two types of heart failure, systolic and diastolic heart failure. So the drugs used in heart failure are ACE inhibitors, beta blockers, diuretics, aldosterone antagonists, digoxin, hydralazine, nitrates, inotropes, and calcium channel blockers. So which of these drugs are used in systolic heart failure and which of them in diastolic heart failure? Because the two conditions are different. Some of the drugs are combined, but some of the drugs are used only in systolic, whereas the others are used in diastolic heart failure. So what happens in systolic heart failure? There is decrease in ejection fraction, decreased cardiac output, stroke volume. And what parameters increased? Increase in preload, increase in diastolic volume, there is dilatation, and third heart sound in systolic heart failure also heard. And the common to both is increase in left ventricular and diastolic pressure. So what are the drugs used first in the systolic heart failure? The cornerstone for the treatment in systolic heart failure are ACE inhibitors and beta blockers. The first drug to be used in systolic heart failure is ACE inhibitors. So when do you use ACE inhibitor and when do you add beta blockers? As in systolic heart failure, the ejection fraction is reduced. If the ejection fraction is reduced up to 40%, then ACE inhibitors are used. And depending on the fluid retention, if there is a fluid retention, diuretics are added to ACE inhibitors. But if there is no fluid retention, diuretics are not given. So what the ACE inhibitors do, they increase the cardiac output. How? They cause vasodilatation and decrease the afterload. So what other functions they do? They decrease the pulmonary capillary wedge pressure. They increase the exercise tolerance and they decrease the mortality. So the choice of drug is ACE inhibitor. First drug until the ejection fraction is reduced up to 40%. So what are the contraindications to the ACE inhibitors? If there is angioedema. If there is angioedema, then what drug you use? Angiotensin receptor blockers. The other contraindications are bilateral renal artery stenosis, pregnancy, we have done it in hypertension, hyperkalemia more than 5 millimoles, serum creatinine more than 3 milligrams per deciliter, and also it is contraindicated in heart failure with hypotension. See, this is the drug of choice for heart failure, but if there is an additional hypotension, then ACE inhibitors are contraindicated in those patients. Okay, if the patient are intolerant to both ACE inhibitors and receptor blockers, then what drug you use? Hydralazine with oral nitrate. Okay, when do you add beta blockers? If the ejection fraction is less than 40%, then the beta blockers are added. But what are the contraindications to the beta blockers? Bronchospasm, bradycardia, and a heart block. Okay, if the ejection fraction is less than 35%, then we add aldosterone antagonist. They include spironolactone, triamcinolone, amiloride, and eplerenone. What the aldosterone antagonists do? They decrease the mortality, decrease sudden death, and decrease with pump failure. What is the caution to be taken with the use of aldosterone antagonists? So they should be used with caution with ACE inhibitors. Why? Or with angiotensin receptor blockers. Why? Because all of them, they cause hyperkalemia. Okay, what diuretics are used? The two diuretics are used in heart failure, furosemide and metolazone. What is metolazone? Is not a thiazide, but it acts at the distal convoluted tubule site where thiazide diuretics acts. What is the advantage of furosemide over the thiazide? The furosemide, they are more potent diuretics, and they works even if the GFR is less than 25 milliliter per minute. That is, they can be used in renal failure. Also, they decrease the pulmonary capillary wedge pressure so quickly that they do it before they do it diuresis. That is why they are very effective in pulmonary edema of acute heart failure. So where do the furosemide acts? They act in the thick ascending limb of the loop of Henle. Why in congestive cardiac failure diuretics are used with ACE inhibitors? Because in congestive cardiac failure, renin-angiotensin aldosterone system is activated. There is increased sodium reabsorption, increased blood volume, and increased load on the heart. So diuretics are used to remove the increased fluid from the body. Which antiarrhythmic is used in heart failure if the patient is asymptomatic? In asymptomatic patient, antiarrhythmic drugs are not used. Now, digoxin. Digoxin is used in systolic heart failure. When do you use digoxin in systolic heart failure? When there is an added atrial fibrillation, digoxins are used. So what parameter the digoxin increases? Digoxin increases the force of contraction, increases stroke volume, increases cardiac output, increases ejection fraction, and it increases the diuresis. What parameter does the digoxin decreases? It decreases heart size, it decreases heart rate, decreases the oxygen demand and consumption by the heart because it reduces the heart size, decreases the end diastolic volume, end systolic volume, and end diastolic pressure. It is especially useful in systolic heart failure, improves the quality of life but does not increase the survival. This is important because ACE inhibitors, beta blockers, and aldosterone antagonists, they increase the survival. But digoxin does not increase the survival, but it improves the quality of life. So how does digoxin increases the force of contraction? Digoxin inhibits the sodium potassium pump. So it increases the intracellular sodium, that increases the intracellular calcium. So increased calcium causes increase in force of contraction. And how does it causes decrease in heart rate? It increases the refractory period at AV node so that it decreases the heart rate. So when digoxin is not indicated, it is not useful in hypertrophic cardiomyopathy where there are thick walls, restrictive cardiomyopathy, dilated heart failure, pericardial diseases, myocarditis, constrictive pericarditis, cardiac tamponade, and mitral stenosis. So what are the contraindications for digoxin? They are hypertrophic cardiomyopathy, dilated heart failure, and AV block. So why there is a digoxin toxicity in renal failure? Digoxin for excretion is or elimination is secreted by the renal tubule. So when there is a decrease in GFR, that decreases the digoxin elimination and increases the digoxin toxicity. What is the most common cause of digoxin toxicity? Is hypokalemia due to diuretic use in heart failure. So what type of heart block the digoxin cause? Digoxin causes all types of heart block. But what is the characteristic heart block by the digoxin? It causes non-paroxysmal tachycardia, atrial tachycardia with AV block. What is the treatment of digoxin-induced arrhythmia and AV block? Atropine 0.6 mg IV or a temporary pacemaker. The next drug used in systolic heart failure is nitroprusside. It is given IV and only in sick hospitalized patient. It is metabolized to thiocyanate. We have done the drug in the treatment of hypertension. What is natriuretic? Natriuretic is also used in systolic heart failure. It is derived from the natriuretic peptide. So it's used only in refractory cases of heart failure. It is a vasodilator and decreases the pulmonary wedge pressure. But this, when you are using natriuretic, what test you can do? You can measure the natriuretic peptide because it is itself a natriuretic peptide, so the results will be wrong. The inotropes. What are the inotropes? Dopamine, dobutamine, amrinone, and milrinone. What is the contraindication to the inotropes? They are contraindicated in hypertrophic cardiomyopathy, and they are used in heart failure with low blood pressure. What is the effects of dopamine, and what is the difference between dopamine and dobutamine? Dopamine is a sympathomimetic, but in low doses up to 10 microgram per kg dilates the renal and mesenteric blood vessels. So it increases the renal blood flow in hypotension and causes the diuresis. Whereas dobutamine increases the cardiac output without vasoconstriction and increases an increase in heart rate. So dopamine causes vasodilation in renal blood vessels, so it is used in heart failure with hypotension. But dobutamine does not cause vasodilatation, so it's only used in heart failure. So what are milrinone and amrinone? These two drugs are inotropes, but they are non-sympathetic, non-catecholamine, non-glycosidic, but they are positive inotropic and vasodilators. So they are used in systolic heart failure. Okay, now the treatment of diastolic heart failure. What drugs are used in diastolic heart failure? The two main drug groups used in diastolic heart failure are calcium channel blockers and the beta blockers. Especially amongst the calcium channel blockers, verapamil and diltiazem. Why they are used in the diastolic heart failure? The calcium channel blockers, they decrease the inotropy, the force. They improve the ventricular relaxation. They decrease the heart rate, and decrease in heart rate permits more time for filling. They promote regression of cardiac hypertrophy, reduce the arterial pressure, and increase the coronary blood flow. They are also vasodilator. The calcium channel blockers, they are contraindicated in systolic heart failure. Why? Because the calcium channel blockers, they decrease the inotropy, the force, and in systolic heart failure already it's dilated and there is very little power in the muscles. The inotropy or the force may be normal in diastolic dysfunction, so they do not seriously impair the stroke volume. That is why the calcium channel blockers, they are used in diastolic heart failure and not in systolic heart failure. So what are the advantages of systolic calcium channel blockers over the beta blockers? They can be used in asthma, COPD, sick sinus syndrome, AV conduction defects, prinzmetal angina, and peripheral vascular diseases where beta blockers are not used. So what the beta blocker do in diastolic heart failure? They promote the regression of hypertrophy, because the main problem in the diastolic heart failure is hypertrophy. They reduce the blood flow, they slow down the heart rate, and reduce the inotropy. So the negative inotropic effects of both calcium channel blockers and beta blockers are particularly useful in hypertrophic cardiomyopathy that also have an outflow obstruction. When do you use ACE inhibitors in diastolic heart failure? If there is hypertension as well, they are used in the diastolic heart failure. What drugs are contraindicated in diastolic heart failure? The ionotropes, the dobutamine and dopamine, and also digitalis, because all of them increases the force of contraction. So particularly in patients with obstructive hypertrophic cardiomyopathy, these inotropes and digitalis are contraindicated because increasing the inotropy can cause increased outflow obstruction. In diastolic heart failure, diuretics are used only if there is pulmonary edema. So what is pulmonary edema treatment? Pulmonary edema, acute pulmonary edema in heart failure is a medical emergency. The pressure, how do you measure it? It's measured by Swansgan's catheter. The morphine, why do you use morphine in pulmonary edema? It decreases the vasoconstriction in the arterioles and in veins. So it's arterial dilator and a venar dilator. 100% oxygen under positive pressure is used in pulmonary edema. The next thing important used is IV loop diuretics. They are the venodilators and diuretic. Decrease the venous return, decrease pulmonary edema before diuresis by decreasing the pulmonary capillary wedge pressure. IV sodium nitroprusside also used in pulmonary edema because they decrease the afterload, arterial dilator, but they are also venodilator. IV dopamine and dobutamine also used in pulmonary edema. Can you apply tourniquets? Yes, tourniquets may be applied on the limbs in pulmonary edema.